And I cannot think of a better person to kick off the Health, Racism, and Communication series this semester. As you all know, he was appointed Dean of our school this past summer, but he will also be occupying one of the newly created presidential chairs, the Presidential Chair in Health Equity. This chair was created for exceptional scholars whose work transcends traditional academic discipline. So just a little bit of background on Dr. LaVeist. He was previously a professor and chair of health policy and management at George Washington University Milken Institute School of Public Health. Prior to that, Dean LaVeist was faculty for 25 years at the Johns Hopkins Bloomberg School of Public Health. While at Johns Hopkins, he was the William C. and Nancy F. Richardson Professor of Health Policy and served as director of the Johns Hopkins Center for Health Disparities Solutions. He received his doctorate in medical sociology from the University of Michigan and did a postdoctoral fellowship in public health at the University of Michigan School of Public Health. In 2013, he was elected to membership in the prestigious National Academy of Medicine of the National Academy of Sciences. Dr. LaVeist has published more than 130 articles in scientific journals, all of which focus on social and behavioral factors that impact health outcomes. He has been a public leader on these issues through lectures and articles in major media. He was also executive producer of the documentary The Skin You're In, which explores the disparities between Black and white health in America. Please join me in welcoming Dean LaVeist.
Thank you. I'm always happy when people applaud before I do anything or say anything. I hope I can live up to that, to the applause. So, some time ago, early in my career, I came across an article that I read that was about race and health. And I don't remember what the article was, so if the authors in the room just don't say anything about yourself, but it was an article. And it was something about the article that really upset me about the way they were using race to talk about this. And as a result, I wrote an essay just one day. I mean, I probably wrote it in about 2 hours. I was just angry. I wrote an essay about race. What does race mean in health services research? Turned out to be the most cited article that I've ever written. I spent probably 2-3 hours on it. And then people started to say we should stop studying race. And then they would cite me as the authority for that statement, which is not at all what my essay said. So I wrote a second essay because I figured, okay, people are not actually reading the essay. Okay? They're reading the abstract or something. And so I wrote another essay and I figured, okay, I will make the title of this essay my point, my thesis. So they don't have to read it. And the title of that essay was Why We Should Continue to Study Race, but Do a Better Job. So I'm going to talk a little bit about this issue of race and health and the way we use race and what it means, how we make progress towards eliminating disparities by race and ethnicity. I won't get into the research methods aspect of this too much today, but there will be future lectures where I'll talk more about that, the whole thing about the research methods that we use and how those methods are problematic for the study of race. But today it'll be more a discussion of the conceptual issues with the study of race that we all have to grapple with if we're going to make progress in addressing this issue of race disparities. Another thing I want to point out is this issue of communications. How you talk about race is really important. And it's very complicated. It's fraught. I had a seminar that I used to do when I was at Johns Hopkins. Had a speaker come in who was speaking about racism and race. And a student in the audience raised his hand and asked a question about using the word racism, whether or not using the word racism is helpful for discussions about race and health, because the word racism can tend to cause people to shut down. And it was a really interesting question, right? And it made me think about, well, I wrote another essay about that too, but it made me think about the experience that I had where I did a lecture where some of the things I'm going to talk about today was in that lecture. And I am certain, absolutely certain, that I never used the word racism in that lecture. Not because I didn't intentionally want to use it, but because it just didn't come up. And the lecture was about trying to make the case that race was not a biological variable, but yet often we still fall into this way of thinking that race is about biology. And after the lecture was over, a student came up to me after the class and said, "Good lecture, but I still believe that race is a biological variable." And that is because when you talk about race, often otherwise rational thinkers lose rationality because it is so politically wrong. So if we're going to have a conversation that's going to lead to progress, we have to be able to talk about these issues. And we have to be able to engage these issues intellectually. And we have to try to keep the emotions at bay and think this through. Why do disparities exist, and how do we eliminate them? That's the question. So this slide is the representation of racial disparities that I like to use. Now this is for 2009, and the reason it's for 2009 is because sometime around 2009, I just finally said, what's the point of continuing to update this slide? It's the same slide. Whether it's 2009, 1999, 89, 79, 1959, the pattern is the same. The absolute rate changes, they've been decreasing for everyone, but the disparity has been consistent, right? And what the disparity shows is that African Americans, in particular African American males, have the highest mortality rate of any group in the country, and that Black women have the highest mortality rate of all females, and that men have a higher mortality rate than women. Which raises the question, why don't we have an Office of Men's Health while we have an Office of Women's Health? I'm not saying we don't need a Women's Health Office, we need that. But whatever offices do, if there's an office that's gonna make a difference, it seems like the guys need an office, right? You know, so most people became aware of this issue of racial disparities with the publication of one of two reports. In 1985, the U.S. Department of Health and Human Services published a report called the Report of the Secretary's Task Force on Black and Minority Health. Not a very creative title, but I think what they lost in creativity, they made up with impact. It was actually a report that alerted me to this issue and changed my career trajectory to address this problem. The other report would be 2002 Institute of Medicine's report on unequal treatment. So in all the years since we've been trying to address this issue, and all of the investment that's come in trying to address race disparities in health, we've made very little progress in raising awareness. So this is data from two surveys that were conducted, one in 1999, the other in 2010, showing that a shockingly small percentage of the US population is even aware that racial disparities exist, and that there's been very little progress over this period of time. So often people, advocates and people who do research in this area say, it's time to stop with the research, it's time to stop with the description, it's time to do something. And I'm very much in agreement with that perspective. It's time for us to do something. But it is still time for us to build awareness, because that's the first step in making change. And we do have to continue to build awareness, because so few Americans are even aware that we have this problem. So, when we talk about disparities, I often find myself talking to people that are not in the health profession. So I'm sure no one in this room subscribes to anyone who does this, but that was a joke. But when you talk to people at dinner parties and things, you know, they finally get me to say what I do for a living. I start hearing these lay theories, and the lay theories usually come out to one of these three things. either, well, there are these biological differences between race groups, and so how are you going to fix that? That's something that's ordained by God. God gave the genes that who He gave to, and this is what we have. Or it's really a healthcare issue. We can just equalize access to healthcare, this would go away. Or, and the most interesting one of all, it's not really race, it's really social class. It's really a positive issue, which I find absolutely fascinating, because even if that were true, which it is not, if that were true, what difference would that make? Is it any more acceptable that poor people live sicker and shorter lives than non-poor people? It's still, to me, you're just turning the same problem on its head. What I want to do is go through each of these explanations, or as I call them, myths, and talk about how these myths creep into our thinking in very subtle ways, and we find ourselves developing policy and invested in the myths rather than ferreting out what are the real causes. And then I'm going to talk about conceptually what race is and how this may help us as we go forward in trying to address health disparities. So first, let me take on this first myth that this is a healthcare access issue. We can simply equalize access to care. I was having a conversation with a member of Congress. This is someone who recently resigned his seat. I won't say the person's name, but he's a good guy. I think well of him. He did a lot to try to do a lot of good for the country. He was, I won't say the name, but I will say he introduced a bill, a single-payer health insurance bill in Congress every year for the last 30 years. He represented a district in South District, Michigan, and recently resigned from the House of Representatives. So, I don't know. But I won't say his name, because I do genuinely like him. So he introduced the bill, yet again, this was a few years ago, and so I asked him, I said, well, what would this bill do to eliminate racial disparity? And he looked at me as if I was absolutely crazy. He said, what do you mean? If we had a single payer system and all Americans had access to health care, then that would eliminate the disparities, because everyone would have access to health care. And I was just, my brain short-circuited, and I wasn't able to respond and just simply say, I don't think that's the way it works. And then the conversation went in a different direction. But here's why that's not the case. So this is a chart from a study published by some guy named LaVeist some years ago. This is a study of 3 hospitals in Baltimore. And I guess I owe it to my former employer to say Johns Hopkins was not one of the hospitals in this study. Although I suspect the results would look exactly like this if it was one of the hospitals in this study. And so we went to these 3 hospitals. We abstracted 10,000 medical records to identify patients that were candidates for coronary angiography, which is an invasive procedure used to diagnose heart disease. And once we identified those patients, we looked at what happened. Did they get a referral for the procedure? Now, 100% of the patients on this chart are insured. So we eliminated the uninsured patients. So everyone had insurance that would have paid for the procedure. Every one of these patients were actually in one of the 3 hospitals. So it wasn't whatever access issues they had to overcome, they overcame those issues. They found their way into the hospital. They got seen. They got a diagnosis. They got a medical record. They had insurance, and they were medically appropriate candidates for the procedure. 100% of these patients should have been referred. But what do we see here? We see that a little more than 82% of the white patients were referred. So we've got a quality problem, because that bar is at 180. But we also have a disparity problem, because fewer than 60% of the African Americans were referred. All 3 hospitals had a cath lab, by the way. So they all had the ability to provide service, and they all had the economic incentive to do it, because they would have been reimbursed. Here's another study that I like to use because I think it drives the point home even more. This is from the VA hospital in Pittsburgh. They're looking here at revascularization, so these are patients who've already been diagnosed. They're all VA patients. They're all at the same VA hospital during the same time period, being seen by the same set of physicians. They all should have been referred for revascularization, but only about 50% of the white patients were referred, half, but half again of the African American patients, about 25% of the black patients were referred. So we have this general quality problem because the white rate is far lower than it should be, but we have a disparities problem. Now here are two examples of patient populations that had access to care, that were insured, they did show up at a hospital, they did seek care, and they even got a diagnosis. And we still find a disparity that is not the result of access to care, to universal access populations. The next one is that there's this biological thing. So there's some gene, right, that causes heart disease and cancer and diabetes and stroke and schizophrenia and HIV and homicide. And, right? So obviously that's ridiculous, right? There's no gene that does that. But the way that this type of thinking creeps into our thought process is a lot more subtle than this. So how many of you are familiar with this drug? BiDil. Raise your hand. One. Okay. Just a hand. Okay. So I'm going to have to tell the BiDil story. For those of you that know the BiDil story, please be patient with me while I tell the condensed version of the story. Right? I'm not going to leave out some details to get through it, but I'll speak as quickly as possible. And as a native New Yorker, I'm a native speed talker, so go with me on this. Okay. BiDil is a drug to treat heart disease, in particular congestive heart failure, which is a debilitating disease. About 500,000 new cases per year, about a 5-year prognosis once you're diagnosed. Very expensive condition because patients spend a lot of time in the emergency department, ultimately with about a 5-year prognosis. It's a terrible condition you don't want to get. So in the 1970s, physicians started to discover, we started to develop new drugs to address heart disease. Drugs that are commonplace now, calcium channel blockers, beta blockers, things like that. And some physicians discovered that if you add these two very inexpensive generics to those drugs, that they were having a very positive impact, very beneficial impact on patients. So they got the idea of, well, let's do a clinical trial and let's see if this new combination therapy is really as good as we think it is. They do a clinical trial. The clinical trial showed that the therapy is wildly successful. They published an article in New England Journal of Medicine, and this is great news, right? We've got this new, highly successful, effective therapy, and it's inexpensive because the two generic drugs are very cheap, right? So this is a perfect scenario, and this is a wonderful story if it ended there, but it didn't end there. It then said, well, what if we put these two generics together and got a combination patent on this? Then there would be an economic windfall that we would get, right? So they do that. And then they license that patent, and they're ready to come to market, except FDA says, no, you can't go to market yet. And the reason you can't go to market is because the trial that you did, that you published in the New England Journal, did not meet all of FDA standards. So you need to do a new trial. Now, if you do a new trial, as I'm sure many of you here have been involved in these studies, they take a long time to pull these studies together. By the time you did a new trial, the drug would be off patent, and you would lose the economic windfall. So what do? You've got this potential economic windfall, but you can't access it because you have to do this trial, and you don't have enough time to do it without losing the patent. So they said, okay, here's what we'll do. We'll go back and do a little data mining of that original data set to see if we can find patterns in the data that help us to make a stronger case or help us to determine what to do next. So they do some data mining, and they discover that this new combination therapy is more effective in Black patients. Now, I said this intentionally. You've heard that terminology before? Is this drug more effective in this group or that group? Okay, wait a second. If I call, what do you do? I call and you, so you know what you're supposed to do, right? You're not doing it. I know we're not in church, but you can get this. I haven't had enough either. Okay. So let's try it again. So you've heard these types of, you've heard about this drug more effective in this ethnic group or that. Yes. You're all teachable. I love that. So what does that mean? Okay. This is what that meant in their case. Let's say that we had, now this is fictitious, right? I'm going to make this up. This is made up data. And so just to illustrate a point. So let's say we had 200 patients, 100 white patients and 100 black patients. We're going to keep it simple, black and white. Black patients, white patients. They have the same exact condition. Now, before I go further with this thought experiment, I should say, this is not a trick question that I'm going to ask you. Although you're going to think it's a trick question because every audience thinks it's a trick question. But I'm telling you, it isn't a trick question. It's a real question. So we've got these two groups of patients who have the same condition. Right? This is a fictitious condition. Right? And okay, they were all diagnosed by the same person using assays from the same lab with the same lot number, and they were analyzed by the same at the same lab. Okay, so I'm not trying to trick you. Same condition. We then give the 200 patients, black and white patients, our pill. And these are the results that we get. 75% of the white patients, 75% of the black patients benefit, and 65% of the white patients benefit. You follow me? Okay. So that 10 percentage point difference, I can assure you, would be statistically significant under that scenario. All right? Yes. I love this audience. Yes. Have we now found a drug that's more effective in black patients? Who says, yes, we have? Okay. Who says, no, we haven't? Who's afraid to answer because it's a trick question? There you go. Right. It's not your question. Okay, the answer to the question is, no, we have not found a drug that's more effective in black patients. We have found a drug that's effective in a larger proportion of black patients. It was effective in more black patients, but it was not more effective in black patients. And because if you were part of that 65% of white patients that benefited, you benefited. If you're part of the 75% of black patients that benefited, you benefited. You didn't benefit more or less, you just benefited or you didn't benefit. Right? So this was, and we certainly have not found this new black drug that's going to eliminate racial disparities. Which is easy. So this was the pattern that they found in their data when they went back and did their data mining. They found a pattern where a larger percentage of black patients benefited. And then they went back and they got a new patent, this time for the use of this drug, BiDil, in only black patients. Right? So in 2005, not 1905, 2005, we get the first drug ever approved for use in one race group. So what do you do next? Well, now we have time to do our clinical trial. So they do a new clinical trial. This time they do a clinical trial only on self-identified black patients. And what do you think they found? I'll give you one guess. They found that BiDil was effective. And why? Because BiDil is effective. Everything you know about these drugs is effective. If it had been an all Eskimo sample, it would have been effective. If it had been an all Hispanic sample, it didn't matter what ethnic group it was. The drug is an effective drug. So they get the new patent, and they come to market with this new drug for just black patients, and with a wink and a nod, hoping that people will realize that it's not only for black patients. So my question is, you're in your treatment room, a patient comes in who you think might benefit from BiDil. Do you prescribe it? To whom do you prescribe BiDil? Do you prescribe BiDil to this African-American gentleman? He has one grandparent from Ireland, one grandparent from Scotland, two grandparents from Jamaica, and he's born in the Bronx. This is Colin Powell. Do you prescribe BiDil to this African-American gentleman? So he's got 2 Kenyan grandparents, and he's got 2 white American grandparents, and he's born in Hawaii, which is part of the United States. It is. It doesn't belong. Do we prescribe BiDil to this African American gentleman? So now this guy's got 1 Chinese grandparent, and he's got a Thai grandparent who also has Chinese ancestry. He's got a white American grandparent who also has Native American ancestry. He's got a black grandparent who also has Native American ancestry. From whom did he inherit his BiDil receptors? And how do you know if the only data you have is his self-report of what his race is? And by the way, if you ask him his race, he will tell you that he is Caucasian, which is literally true in his case, right? So maybe it would be effective. This is Tiger Woods. And so finally, what about this guy? He looks like a black dude to me. Do we prescribe BiDil to him? Well, this is VJ Singh, who is from Fiji and is not an African American at all. Now, hopefully, VJ will never need BiDil, but my hope is that if he did need it, it would be available to him, because what we know about the drug is that it's an effective drug. But we've now created this drug that is to be prescribed only to one ethnic group, when all the science that we know tells us that it is not a race-specific drug. This is what race is: a source of confusion when we don't apply the same logic, the same scientific thinking that we use in virtually everything else that we do in science. So, and there's the final myth, that it's not really race, it's really socioeconomics, that's social class, which I'm just bewildered by this one. But this was the easiest one to dispel. This is some charts from the Health Interview Survey looking at race differences in a variety of outcomes. And it doesn't really matter that much what the health outcome is. There is a race disparity at all levels of education. So I like to tell my affluent African American friends is that you're not going to educate or income your way out of this problem. There is still a race disparity, even at the highest levels of income and education. A couple of charts showing income. This is from the medical expenditure panel survey. And again, it doesn't matter very much what the condition is. This is the most interesting chart here. This is the only case that I know of where disease risk actually increases with income, and this is for hypertension in African Americans. Your risk of hypertension actually increases as you go to higher income levels. And I'll say more about that later if anyone cares to hear my hypothesis about this one. This is from a paper that I have not yet written out, but will be publishing soon. Okay. At the core of the question of this is, what is race? What is it? It used to be, even in the research that we do, that we would train interviewers not to ask people their race. If you're old enough to remember that, certainly most of the 1990s, we would train interviewers, don't ask their race or gender, because it was thought to be insulting to the person who was enrolled in the study. So how do you measure race? You look at a person and you make an assessment of who you think they are, and then you check a box on the form. And that is what the race variable was in most of the studies. Now I think the protocol typically is to tell people to ask every single question about how obvious it can be. I had a friend who did a study, it's a really informal study that, this is how informal it was. He called around to obstetric students where you meet people and said, how do you guys collect race in your unit? And he got as many different answers for as many different hospitals that he called. One hospital, well, we give the form to your parents, and whatever they do, they do. Another place was, well, we look at the mother, and based on how she appears, check the box. Other hospitals said, well, we look at the medical records. Whatever the mother's medical records said, this we go with. This is all over the place. This is the variable that we consider a demographic variable on par with income and education and sex and other indicators that we think of as these solid variables. When in fact, what they really are what the really is a political variable, determined by political considerations. The origins of this concept go back to the 1600s when naturalists, explorers began traveling the world, identifying humans and other parts of the planet that look differently. And just as they were classifying animals and creating classification systems for animals, they applied the same logic to humans and decided that skin color was a sufficiently important differentiation between one population and the next, that we would create different groups, and created these 5 groups. Caucasian or white, Mongolian or yellow, Malayan or brown, Negro or black, and American or red. 1600s. The United States doesn't have an official definition of race until publication of Directive 15 in 1977. And if you look at Directive 15, it is the same 5 categories that evolved out of the 1600s. Still the same category we use today. There's been an update to Directive 15, but it's the same pattern, basically. Looking back at the census, now, I should point out that I know that I'm breaking every rule of PowerPoint slide making here. It's to make a point. I'm going to show you in the next 3 slides the way that race is measured in every census ever taken in the United States, beginning in 1790. And you see that rarely do we even measure it the same way in 2 consecutive censuses. So 1790, free white males, free white females, and all other free persons and slaves. 1800, we add Indians not taxed. 1930s, we include, 1820, 1820, we include free colored persons as a separate category. 1850, we add mulatto, so people that are mixed race. 1860, Indians get added. And in 1880, they add Chinese, so now we have nationalities being added here. Right? We're including nationality with race. 1890, they decided mulatto was not enough, so we had to add quadroons and octoroons. And another nationality here, Japanese. Moving into the 20th century, we start getting religious groups added in 1920s, where we add Hindu. So now we've got race, nationality, and Hindu. 1930, black becomes Negro. Mexicans get added. Koreans get added. Moving to the second half of the 20th century, 1970, Negro becomes black. Notice how many lines now I need to use to get all the categories in. Do 3 lines by now. The point is, the way race is measured, the way it's designated, the way it's identified, is a political decision. A set of decisions are made through a political process. I was on the 2000 census. I was on the Secretary's task force on data, where we advised the Secretary of Health and Human Services on data issues. And people would come in arguing for a new box for their group. And we were the group that held the hearings and would advise the Secretary. Everyone wanted their own box, not realizing that the problem is the box. The problem is the box, because the box designates categories. And what we're trying to do with designating race in this way is we're taking human variation, which is continuous, not categorical, and we're trying to place people into these categories. So there are many people that fit comfortable into the categories, but there are many people that don't fit comfortable into the categories as well, because human variation is continuous. Now, whatever race means, it means something, and it means something profound when you look at the racial disparities that we document clearly and consistently across all disease categories, right? But what it means is something that is more in the social realm than in the biological realm. So Gender disparities are not caused by genetics, healthcare, access, or socioeconomic status, then what is it? And I argue that what it is the fact that we live in the country together, but we experience the country in very different ways. Because of structural racism, because of segregation, it facilitates differential exposure to health risks and differential access to resources that are protective of health. And if you just think of different communities, even here in this city, that are predominantly of one racial group versus another, and the differences in the infrastructure and the resources in those communities, that is what tracks with race. That is what correlates with race. That is the spurious correlation. Race is measuring exposure to differential types of communities and community resources. And especially when we rely on national data, it becomes problematic. So the country is a vast country that spans 11 time zones, if you include Hawaii, which is part of the United States. 11 time zones. That much geographic breadth, right? And it would be like if you turn on Good Morning America to get the weather, and they said today the average national temperature will be 42 degrees. That is a calculable number. You can calculate that number, but how helpful is it? When you don't take into consideration that we're not living in the same communities, we're not living with the same exposures, or access to the same resources, and we see race differences, we assume that the race differences are about something endemic to the race groups, rather than that the race differences are about different lifestyles, different communities, different exposures that people are experiencing. So this map was created at the University of Virginia based on the 2010 census. They placed a dot representing every American in the country, over 300 million dots. Must have taken them a long time to place these dots. And they're color coded. So the blue dots represent whites, or white people. The green dots represent black people. Asians represented by the red or orange dots. Hispanics are yellow dots. So let me zoom in on a city. You might recognize this city. City of New Orleans. When you look at how the dots are displayed across the city, you see that this city, like other cities in this country, is massively racially segregated. There are clear places where the blue dots end and the green dots begin. And this is I've done this for virtually every city in this country. The pattern is the same, so don't feel bad. New Orleans is no worse than the other cities. But it's just as bad as the rest of the country in terms of its segregation. So when you think about it, those of you who know the city, think about the neighborhoods that are represented here. What are the amenities? What are the resources in those neighborhoods that are dominated in blue versus the ones that are dominated in green? This is a source of variation that we never or rarely account for in the research that we do. Rarely. So can we simply take a person living in Center City and another person living in Carrollton and assume that we can control for everything and make comparisons between these two people when we don't measure this? The fact that they're living in different neighborhoods, different communities, different environments, with different exposures and different levels of access to protective factors. So there's been a literature, a growing literature on the relationship between segregation and a variety of health outcomes, documenting that communities that are racially segregated, in those communities you find communities that are segregated and black in this country, you tend to find worse health outcomes. But when black and white people are living together in the same environment, you find that the health outcomes are more similar because you have the same exposure, similar lifestyle, and similar outcomes. I would argue that much of the disparity, not all of it, but much of the racial disparity that we see in the research that we do is the result of racial segregation, which results from structural racism, which results from policies that we've had in this country over generations that produced racially segregated cities, such as New Orleans. So a couple of those studies. This is Washington, D.C., which is a really interesting way of depicting it. This was done by the Robert Johnson Foundation, where they took the D.C. metro. And if anyone knows D.C., you know it's not a very big city. To my thinking as a New Yorker, it's a tiny city. But if you're at in the center of the city there, which is Metro Center, depending upon which line you get on to go home and which neighborhood you're going into, life expectancy can vary dramatically within this very small geographic area. So in Northern Virginia, 80 years old. In Montgomery County, Maryland, 81. Prince George's County, which is predominantly African American, community, 75 years old. Depending upon which train you get on to go home, we can predict life expectancy. They've done these maps in many other cities as well. So, the point, defining race is complicated, very complicated. We usually do it with a simplistic binary variable. We don't account for the fact that there's dramatic variation being captured in that variable. So a lot of the models, a lot of the studies that we do are likely to be misspecified because of that. Now, before I depress you, I should say, so you go into PubMed, you put my name in, and you will find that I've committed some of the same sins that I'm talking about here today. So it's okay. But the point is to go forward and sin no more. Not, okay, that's the point. Repent and sin no more. Not, sorry. Race differences in health are not simply a matter of access to health care. There is no scientific evidence of biological differences between race groups. Now, I would say that there could be scientific evidence based on epigenetic differences. You know, epigenetic differences are not endemic to the race groups, but they are correlated with the race groups because they are measuring the genetic expression of the exposures that they have. So it is possible that you will find higher prevalence of some genetic characteristic in one race group versus the other. And my argument is that it's likely that it's an epigenetic phenomenon, not something that is, it's not some black gene that produces all of these diseases that you see, these disparities happening. Race differences are found among affluent people. So thinking that because you have a certain level of educational income and you're going to be saved from race disparities is a mistake. And race, it seems to me, is primarily caused by exposures that occur because of structural racism. So now, the issue of communicating about this topic, about race disparities, is something that I think a lot about. How to communicate these things to people in ways that people will get it. And what I find is that usually when I talk about these issues, one reaction is confirmation. There was some segment of this audience likely who simply said, yes, this all makes sense to me, I get it, I'm good. But that's not the only reaction. There's also what I call the tune-out. That occurs when you use words like racism and things like that. People kind of drop, they turn it off, and they don't want to engage the topic. Again, trying to tee that up to you get it, so that you would be thinking about that, so that hopefully those of you who may have a proclivity to tune that out would not be so willing to do that, and might be willing to listen and engage it intellectually, not emotionally. But I don't know. Then there's also the backfire effect. The backfire effect is very problematic. And the backfire effect, I think, happens often to racial ethnic minorities when they see this. Because they look at it and say, here we go, yet again, we are the disadvantaged group. And that leads people to not take action. I implore you not to let the backfire effect impact you. Because what we need is a somewhat emotional response. But that emotional response needs to be an activated emotion, not depression. It needs to be passion. It needs to be outrage. It needs to be something that activates you to action, to make a difference, to try to impact this problem. We're here today to talk about race disparities in health. But there are, in fact, I say, 4 great disparities that cause each other and are caused by each other. And until we engage all 4 of these disparities together, we're not going to address the health disparities problem. So today we're meeting to talk about health. There's another group somewhere else in this city probably talking about the other 3. But we need to be talking to each other. We need to be talking across sectors to make a difference. And these other disparities are, of course, health disparities, but also wealth, education, and criminal justice. And by criminal justice, I'm talking about aggressive policing and mass incarceration. Each of these are caused by each other, and each of these cause each other. So we know that education is one of the best known predictors of health, and we also know that children that have health problems are less likely to be able to develop educationally, be able to succeed in school. We know that people in prison have very high rates of illiteracy, and people often wind up in prison because of frustration resulting from undiagnosed and untreated learning disabilities that we don't diagnose in the public schools. We know that people are able to avoid prison because they have the wealth to afford high-quality legal services, and that there are many people in prison because they don't have the ability to afford that. And the best way I can think of to ensure that a group of people will not develop wealth is to be in prison between the ages of 17 and 34, which is when most people develop the human capital necessary to create wealth. The health and wealth relationship is probably the best known correlation we have in health research. And we know that people wind up in prison because of undiagnosed and untreated mental health conditions. And that people come out of prison sometimes sicker than they were when they went in. Now, none of that should be a surprise to anyone in this room. None of this is news. But it's not the way that we think about the work that we do. There is no important problem that can be resolved by any one discipline. No important problem. They all require multidisciplinary approaches. So, in closing, let me ask you this last question as I close. How many of you here are aware that there are more Black men in prison than in college? Okay. How many of you actually looked that up to see if that was true?
It's been dispelled, right?
I even heard President Obama make that statement once, which stunned me, because I did look it up to see if this was true. So let me share, as a researcher, and a lot of you are researchers too, so shame on you. I'm going to show you what I found when I went to the U.S. Department of Education and U.S. Department of Justice data and pulled it in to see if this is in fact the case. Because I grew up in one of the toughest neighborhoods of Brooklyn. I know a lot of people that went to prison, but that just didn't track with my own personal experience that there would be more Black men in prison than in college. It didn't make sense to me. So I looked it up. So in 2006 was when I first did this. That year there were 36,800 Black men in prison. Now that is an unacceptably high number. So please don't interpret anything I say to suggest that I think that that's acceptable. That is not acceptable. But that year, there were 896,000 Black men in college. So it wasn't true that year. Now, okay. The prison population, adult population, can be any age, right? Any, up to 100 years old. The college age population is typically going to be between 18 to 22, 23, something like that. So the best we could do of lining up the age categories from these 2 databases was the age range of 20 to 29. So in that year, 310 Black men in prison, 480,000 Black men in college, still more Black men in college. So then I said, okay, was there ever a year where that statement was true? So I went back as far as I could with data from these 2 data sources. And this is what I found. That there were 2 years where the numbers were close. But even then, there were more Black men in college than prison. So not only is that statement not true, it never was true. It was a lie the first time it was said. It is still a lie now. And if you get nothing else out of this lecture, I ask you to join me in my one-man crusade to stop this horrible lie and myth from being spread. Because if you believe this, though, how does that impact you when a black male shows up in the hospital for care? Do you engage him in the same way? Do you get the same level of trust? How is his healthcare impacted by that? In subtle ways, potentially. Subtle ways, potentially. Right? What is it about black men that that lie can be believed? Think about that for a moment. If I said there are more Asian men in prison than in college, you would look at me as if I was insane. Right? You would never believe it. You would never repeat that statement. But yet, this statement is being repeated. So, that's my final plea. Join me in my crusade, please, to dispel this. Please pass the word. It's a lie. It's not true. It never was true. It was a lie the first time it was said, and it's still a lie now. And I thank you for your attention.
Nadi has a mic over there, and Beta has a mic over here. So please raise your hand, and we hope to get to as many of the questions as we can.
Don't all leave at once.
I think people have classes.
Well,
And
go to
please
class.
make sure to turn in your evaluation forms in the back.
So I gather there's no questions.
Oh, there'd be no questions.
Hi, I have a question. I'm really glad to know that there are more black men in college than in prison. I
Thank you.
was someone who raised my hand because I've seen it on the news.
Now we got to get more in this college. Right?
Yeah. One thing I want to ask you about is the numbers of black men in medical schools.
Yeah.
I mean, my own personal experience as a faculty member is that the numbers have gone down. At LSU right now, we have one African-American male student in our class, first year in class. And from what I've read, this unfortunately seems to be a nationwide trend. And I was wondering if you could comment on that.
Yeah, it is. So the numbers really have not changed. I haven't seen the numbers for this current year, so I can't speak to this year. But up until last year, the numbers have consistently been between 4 and 5% since the 1960s. That is nationally, and it's been a tough problem to address. There's been a number of attempts to deal with that. I was on a commission once, Dr. Lewis Sullivan headed up to deal with this. And we haven't been able to address, to solve the problem. Part of it is a pipeline issue. I mean, by the time you're ready to successfully apply to medical school, you have to pass through many levels of education. People get weeded out along the way for a variety of reasons. Some of them not necessarily fair or equitable reasons. Some of them because of inadequate K-12 education in many of the cities. The African Americans are still disproportionately urban settings attending public schools, which is a national problem. That the schools are less likely to have sufficiently strong science education to prepare people for medical school. So this is a problem, not just in medicine, quite frankly. I think it's a problem in many fields. And those cases where you do see large numbers of African Americans who tend to not be in the sciences or the quantitative areas as well, and it's because of the same problem. So what I'd like, since I've got the microphone here, I am the dean, so here's my chance to say something about what I'd like to, I'd like to see us as a school work with. Here in Louisiana, we have 4 historically black colleges, and one of them has 2 campuses, so you can take 7, really, it's 2 different schools. So since they've got 5 different campuses, I've already reached out to some of the presidents at those schools to connect with them with the idea of establishing a public health academy where we would start training students from those colleges as well as undergraduates here at Tulane, and to prepare them to be able to apply directly into PhD programs coming right out of their undergraduate degrees in public health. Hopefully, some portion of those students would be coming to Tulane, but I'd love to see them go up to all of the leading schools of public health and grow the pipeline. Yeah, you asked the question about medicine, but if you look at the public health, medicine, and nursing, nursing is doing far worse than medicine. Nursing is by far the worst in terms of its diversity, which is shocking because you would think that they would probably be doing better. Public health and medicine generally do better than nursing does. But all three fields are woefully inadequate in the diversity of the field, and certainly the diversity of their faculties.
Hi, my name is Katie. First, I just want to say thank you, Dean LaVeist, for your presentation. I just was interested when you mentioned the part about, people of different races kind of seeing the world in a different lens. And I'm just wondering, I mean, obviously this is a multi-sectoral issue, but do you have any advice on just like the day-to-day things that we can be doing in our lives to try to equalize this lens that people are seeing the world through? I have a 4-year-old niece who is biracial, and at 4 years old, she looked at me and said, "I wish my skin was the same color as yours, Auntie Katie." And that broke my heart. How does that happen at 4 years old? So I'm just wondering what we can do, like on the day-to-day, conversations or interactions, or if you have any advice on how to.
Well, I think it is those very late interactions. If we're talking about the lens issue, so the issue that I was talking about really wasn't so much individuals' worldview or perspective, but rather the actual physical exposure to health risk and availability of resources in different communities. So if you're in certain communities, the quality of the food that you have access to is different. The levels of exposure to health risks, such as, lead paint, for example, diesel fuels, major roads running through your neighborhoods, things like that. Certain allergens, particulates. Maybe not in this city, because this city is so old that everybody's got cold houses. But nationally, you look at that. So I'm thinking more from an environmental justice standpoint, those environmental exposures and other resources you need. So, for example, quality of healthcare. There's a study that I did. Maybe if I do an invite for a presentation, I'll talk about some of the data that we've collected around this thing, where we studied a community in Brooklyn, Baltimore, that is racially integrated, and we were able to find no race disparities in that community, because everyone in that community was sick, because that community is a community that's going to produce bad health outcomes, and no one is going to be protected in a community like that. With no access, there's no supermarket, there's no bank, there's no fast food. Even the only food that's there is mom and pop's fish fries, things like that. And in a food environment like that, in a housing environment like that, it's going to be bad health outcomes for everybody. So that's one thing. That's these exposures. Now, the lens issue you're talking about is really more, I think, from a psychological standpoint and a cultural standpoint. I think the only way that we deal with that is by people interacting with each other, people getting to know each other, people finding commonality. That's hard to do if people are living in segregated environments where they're not interacting with each other. And I think that's the case in much of the country. So here in an environment like this, in a school where people come together in the same room, in the same building, reaching out to people of other racial and ethnic groups, building those relationships, you'll find that people are more, certainly my experience has been that people are more common, more alike than they are different. And the differences like skin color tend to, when you get past the superficial, when you actually get to know a person, there really aren't often that many differences. People will find across the political spectrum, regardless of their skin color, people who have all different points of view. So engage with people. That would be my advice.
Hello. Hey. I'm I'm curious how you envision data collection for large groups that would both give us an accurate picture of how people's lives are affected by their melanin and also resist pigeonholing the people we're collecting data about.
So I'm sort of thinking maybe I should have worked the data on the study and talked about it from that standpoint. I was told it would be like a community audience, but not mostly researchers, so I didn't want to go with the science thing, so it wasn't conceptual. But one of the solutions that we came up with was to find these basically integrated communities to see what happens, right? So what we do typically is we take a national data set, and then we try to use statistics to adjust for differences between populations to create equal groups. That's what multivariate modeling is trying to do. Right? We try to adjust, we try to create equivalent populations that allow you to make comparisons. Now, this is inadequate because there's so much unmeasured variation. And if you don't know everything to measure, which of course we can't possibly know, your model is going to be misspecified. For the non-research, I'm sorry to be using technical terminology, but I don't have to talk about this stuff. So your model is going to be misspecified because you're going to have unmeasured error. Our idea was, okay, what if we, instead of trying to deal with this problem through statistical analysis, what if we could deal with it with study design? So we can design the study in such a way that we can parse out the noise by looking at people who live in the same social environment, so that the social determinants become a constant rather than a variable that we have to measure. You see what I mean? And that's what we did with that study. So that's one strategy. The other strategy, if you have, you're going to look at a big geographic area or multiple areas, is that there are multiple ways to measure race. So one way is to ask the respondent what race they say they are. Another is for and we've done this in some studies too, that the interviewer identify what race they think the person is. CDC actually did an experiment using BRFSS. For several years they did this, where they asked people what their race was, the normal question that they use. Then they also said, well, what race do people sometimes also think they are? And you had variation there. And what they were able to show is that what race people think you are is a stronger predictor of health than the race that the person said they was, which is an interesting finding. I can give those references if you want, but I don't know what's on my head. Kamara Jones was the author of several of those papers. So if you look at them, C.J. Jones, you'll find his name from CDC. You can also, there was a couple of studies I've seen where they actually used light meters to measure skin color, how dark the skin is. So if you triangulate something like that, you use a light meter to measure skin color. You ask the person their race, you ask them what group people can think that they are, and you let the interviewer ask, and you have these different measures of race. Maybe that would help. You have to also consider ethnicity. So within race groups, there's differences in nationality, for example. So what are white Americans? White Americans are people who have ancestry from the entire geographic expanse of Europe, right? But a scientist in Sweden that wants to do a clinical trial would probably only use Swedish people in their trial. Someone in Greece would probably only use Greece if they were doing that study, right? But the descendants of people from all of these groups is what white Americans are. We will never account for that source of variation, which likely exists. We also know historically different European groups have had different levels of discrimination when they came to this country. And they've had different trajectories and histories in this country. But this is another source of variation that we don't account for, right? That's just among whites. Black Americans, also, very African Americans, those who have ancestry through the Middle Passage come from a huge geographic expanse of Western and Central Africa. Then you've got more recent immigrants from Africa who have now come into the country, and you've got people from the Caribbean. So each of these groups have different trajectories. That's a source of variation that we don't account for. So my proposal would be account for that, measure that variation. And then Hispanics is probably the most problematic. I don't know. What is that? It's people that come from countries that were once colonized by Spain. That's the best I can do. Plus Brazil, right? That's the best I can do. So well, how about we parse that out and not assume that Mexicans are similar to Cubans? When you think of U.S. immigration policy, if you are from Cuba and you can get in a raft and get far enough from the island, the U.S. Coast Guard will come get you and bring you into the country. If you're from Puerto Rico and you come here, you're already a citizen. If you're from Mexico or Central America, we're trying to build walls to keep you from coming into the country. So all of those groups we call Hispanic, but they're very different groups. And so I would say future research needs to take into consideration these sources of variation that we ignore with this very crude bi-category variable that OMB calls race.
Good afternoon.
I will promise to answer this question quickly on previous answers.
Good afternoon. Naomi Osaka appeared to go from Haitian and Japanese to just full Japanese in one tennis tournament. So, it happens. So my question to you, though, has to do with mental health and access to it and how certain communities view it as a real thing versus, you as a woman or an app and that will solve his mental health issues. And so real quickly, a story that a friend of mine who went to law school at Florida says is that many of the students of his peers took like cocaine and other things, drugs for ADHD, to make them attend in class better and study longer. Whereas where he's from, and me as well, we would never even thought of that being like an option to doing one in school. So I was wondering like how communities can view those things as a help more than not necessarily cocaine, but other drugs as more of a help to them and in their outcomes versus seeing it as an athlete.
Well, I'll answer that question this way. I think what you're getting at is the hope that there is. So I mostly talked about this biological concept of race, and I've talked about the structural issues found in policy. But there's also a cultural dimension to it, right? At some point, we're all told what group we belong to, usually by our parents. And this is our group, and this is the culture of our group. This is what we eat. This is how we celebrate. This is what we do. These are the rules of our culture, right? We're all taught that. So there is cultural variation that also is correlated with race. Now, race is not culture, of course, but cultural variation is there. I think that's what you're pointing out, that you see these differences that they track with race. But I think even cultural dynamics more so than race, but they do have implications for racial disparities because people with different behaviors. So there's a paper we did on that called Black Hispanics, Black or Hispanic, where we looked at Black Hispanics and compared them to non-Black Hispanics and compared them to Blacks that are not Hispanic, and found that they actually are a third group, a separate group, that really needs individual attention from a health education standpoint. So I think if we did more analysis like that, we would find that there are more and more of these smaller groups if you take a more intersectional approach and start parsing that out. So it's probably the case that Black students in that same law school who maybe grew up in more of a white environment with more white friends, they might be more likely to use those drugs also because their cultural reality is very different and they grew up in a different environment. And so I would propose it, but something like that is probably more a function of where you grew up, how you grew up, and what you see as acceptable as a function of what your background is. I hope I answered your question. Best I can do.
Good afternoon. I just have a really quick question. Considering all of the variables that compounded that you say go into
health disparities via race, whether it be quality of healthcare, access to healthcare, education, those things. If we take an example like Washington, D.C., where people feel like they're losing their culture due to like gentrification, would you say that gentrification has had like a positive impact on the quality of healthcare?
Gentrification, a positive impact on the quality of healthcare. Extremely complicated question. Gentrification is an extremely complicated problem. I don't see that gentrification has had an impact on healthcare. It has an impact on displacing people and moving them around into different places, which may influence their access and their ability to access healthcare and other resources that they're accustomed to, impacting relationships, friendships, their social networks impacted by it. What I've seen in Baltimore, where I was living up until a few months ago, when they did regentrification in certain neighborhoods, what happens is that the health statistics dramatically improved. Why? Because the people got healthier? No, because the people got moved out and new people moved in that were healthier and more affluent, and new resources and new amenities moved into those neighborhoods. And so, yeah, the statistics got better for that census tract, but it's because they just swapped out the people, put in new people. I think that's what gentrification does. It just displaces people and moves them to different places and spreads it. So there was when they imploded the projects, the high-rise housing projects in Baltimore, I was talking to people in the health department there who showed me this map they had. There was this one housing development that was so massive, it was its own census tract. Huge place. They showed me the STI rates, right? And it was very high in that census tract. They imploded the housing development, and then you saw the cases just spread throughout the city. So now the rates of STIs spread throughout the city, and the rates in that census tract plummeted, of course. That's what gentrification is to me. It's moving people around. It's moving people and people take their problems with them. So the problems move into other communities, and that is a big part of the challenge, because then people don't want people from those neighborhoods moving into their neighborhoods because they're taking their problems with them. So it's an impossibly complicated problem, I think. There's another hand over there.
Do you see that the Affordable Care Act had any impact on healthcare disparities in the last few years, negative or positive?
I think it's definitely had a positive impact, not as much as it could have, but the Affordable Care Act has had a positive impact. It certainly has dramatically reduced the number of uninsured people in this country, and I think that's a good thing by any standard. That's a good thing. So I would answer it that way. I would also say that there are 68 health equity provisions in the Affordable Care Act. Very few of those provisions were funded, so they were never implemented. So the potential was much greater in terms of what that law could have done. But to answer the question, yeah, I think it's definitely been positive. Just the very fact that just eliminating discrimination, guaranteed issues. Eliminating discrimination among people who have pre-existing conditions. That alone, I think, is a huge improvement for everybody. And so I think that's, to me, very easy. Yes, it has helped. Has it solved the problem? It hasn't made the problem go away. It hasn't brought health equity, but it certainly has moved the needle in the right direction, I think. Okay, I think we are done here. Well, thank you.